Okay, hope you're doing well. So today you're going to discuss about pneumonia, and your presenter is Meshack Kitaka. So pneumonia, we basically define it as an acute inflammation of the lung parenchyma distal to the terminal bronchioles. And the terminal bronchioles consist of the bronchiole, the alveolar duct, the alveolar sacs, and alveoli. Pathogenesis, the microorganism gain entry into the lung through one of the following ways, or rather one of the following four routes. We have inhalation of microbes present in the air. We have aspiration of microorganisms in the nasopharynx and oropharynx. So under point one, inhalation of microbes in the air, you realize that the air is not sterile, so it contains a lot of microbes. So as we breathe normally, one can get pneumonia through inhalation of the microbes. So aspiration of organisms from the nasopharynx and oropharynx. Now this one usually occurs especially in comatose patients, those who are unconscious, like those who have cerebrovascular accidents, those who have an injury to the head, those comatose patients due to various reasons, one or another. Then you have hematogenous spread from a distant focal, like the patient might be having a liver abscess. Then the infection or the microbes might spread into the lungs through the blood. Then one ends up getting pneumonia. We also have direct spread from a joining site of infection, like for example, one might be having tonsillitis, and as a result of tonsillitis, the microorganism may descend into the lungs, developing into pneumonia. So we have various defense mechanisms of the body, and one of them we have the nose containing some hairs that act as filter. They filter the dust particles and the microbes to some extent. Then we also have mucociliary action of the lower respiratory airways. So the lower respiratory airways do have a ciliated epithelium that tend to it causes a flippering effect when the microbes or other foreign body lands into the lower respiratory tract. So the cilia's tend to flip the mucus upwards so that when it reaches the upper respiratory tract, it can be coughed and spit out. So another defense mechanism is the presence of phagocytosis alveolar macrophages. So in your anatomy, you realize that you learn three types of cells that we have in the lungs, and we have the type 1, type 2, and the type 3. So this, the third point, is basing on the alveolar macrophages, that is the type 3. We also have immunoglobulins, the antibodies still in the respiratory tract. So failure of these three defense mechanisms might result to, or rather maybe predispose someone to getting pneumonia. So despite having all those defense mechanisms, the lung is still vulnerable at getting an infection. And it may be due to the following reasons. One, we are having microbes, so many microbes are airborne and they are readily inhaled into the lungs. So as you take in your oxygen, then you might end up introducing microbes because the airway is not, sorry, the air itself is not sterile. It contains a lot of microbes. Again, we also have the nasopharyngeal flora that are regularly aspirated during sleep, even by healthy individuals. So when you are asleep, you are somehow unconscious, it quotes. So you might as well aspirate those nasopharyngeal floras. We also have lung disease of the lower local immune. Lung diseases often lower local immune defenses. Like for example, if you have a smoker, smoking may result to a lung disease, and smoking by itself tend to destroy the cilia. So they feel the defense mechanism of cilia is lowered to some extent by smoking. We have predisposing factors that may predispose someone to getting pneumonia, and one of them is altered consciousness, especially those patients who are in coma, those who have cranial trauma, those who have seizures, those who have cerebral vascular accident, those who do overdose of drugs and alcoholism. They tend to get aspiration of gastric contents into the lungs. You also have depressed cough and glottic reflexes. You realize that uh, we have the mucociliary transport that tends to flip away the microbes in the foreign bodies. But again, when it reaches the upper airway, it is either coughed or spit. It is coughed and then it is spit out. So if you cannot cough, whether the cough reflex, if it is impaired, if it is depressed, then most likely you'll not be able to clear those foreign bodies and microorganisms. Another point is impaired mucociliary transport. So like for example, those who smoke, cigarette smoking, you also have viral respiratory infections. Immotile cilia syndrome, it's another point, and inhalation of hot or corrosive gases and old age. All those, they contribute to the impairment of mucociliary transport. So therefore, the cilia cannot effectively clear the mucus that has trapped the foreign body and microbes at large. Another point is impaired alveolar macrophage function. This may occur in case of hypoxia, starvation, when one has anemia, pulmonary edema, and viral respiratory infections. They tend to impair alveolar macrophage functions. Another point is endotracheal obstruction. This may occur due to tumor or other foreign bodies. So even if you have the cilia functioning very well, but again, if it meets an obstructed area, then it cannot clear, predisposing you to getting pneumonia. We also have leukocytic dysfunctions, such as those who have acquired immunodeficiencies like HIV and AIDS, immunosuppressive therapies, the chemos. Somehow they tend to cause leukocytic dysfunction. But again, the disorders of the lymphocytes can as well be congenital or acquired. So as for case of acquired, you have the AIDS and immunosuppressive therapies. So classification of pneumonia, it can be classified on the basis of anatomic part of the lung parenchyma, and basically they are traditionally classified into three types. We have the lobar pneumonia affecting the lobes, the bronchopneumonia affecting the lobules, and the interstitial pneumonia. We can as well classify pneumonia according to the etiology, which we call etiologic classification, and it is basically classified into three main groups. We have the bacterial pneumonia, where the bacteria is the organism causing. We have the viral pneumonia, where the virus is the one that is causing the pneumonia, and lastly we have pneumonias of other etiologies. All the others, the fungals, pneumonia of the immunosuppressed patients, all those, they are under that. Then you have the clinical setting, where you can classify it as community acquired or hospital acquired pneumonia. Bacterial pneumonia, the causative organism, we have the Streptococcus pneumoniae being the commonest. Then others you have in Haemophilus influenza, Moraxella catarrhalis, Staphylococcus aureus, Legionella, Pneumophila, among others, the Chlamydia and Coxiella barnetti. For viral pneumonia, we have influenza type A and B. We have respiratory syncytial virus. We have human metapneumovirus. We have adenovirus. We have rhinoviruses, rubella viruses, and varicella viruses. Then the other way we classify the others, other etiology of pneumonia, we have aspiration pneumonia. This is the other classification of pneumonia. The way we had the bacteria, the viral, and then the others. So this one lies under the others. We have aspiration pneumonia, whereby you may get streptococcal pneumoniae, you may get Staphylococcus aureus, H. influenza, and Pseudomonas aeruginosa. Chronic pneumonia, this can be due to Mycobacterium tuberculosis. You may get histoplasmosis, you may get coccidioides, among others. Necrotizing pneumonia in lung abscesses, we basically have anaerobic bacteria, but again it is, the anaerobic bacteria, they're extremely common with or without aerobic infection. And under that, you may get Staph aureus, Klebsiella pneumoniae, Staphylococcus pyogenes, and the type 3 pneumococcus, which is uncommon. Pneumonia of the immunocompromised host, we have the cytomegalovirus. So you realize that this is a virus, it is viral, but again, it has been classified under pneumonia of the immunocompromised host. Then you have pneumocystic cerevisiae, which is common in those who have acquired immunodeficiency disease syndrome. We also have Mycobacterium avium complex. We have invasive aspergillosis. We have invasive candidiasis. Morphologic features. We have Leonec original description divides lobar pneumonia into 4 sequential pathologic phases. We have stage of congestion, that is the initial phase. We have red hepatization, that is in early consolidation. You can still call it as early consolidation. We have gray hepatization, which is late consolidation, and finally resolution. So under stage 1, the stage of congestion, which is the initial phase, usually presents as an acute inflammatory response to bacterial infection and usually lasts around 1 to 2 days. Grossly, the affected lobe, it may appear enlarged, it is heavy, it is dark red and congested. When you cut the surface, you will realize that you're going to get a bloody stained frothy fluid. Histologically, remember we say that this one represents an early acute inflammatory response. So in acute inflammatory response, you're going to get dilatation and congestion of the capillaries and the alveolar walls. You also have edema fluid in the air spaces. We have few red blood cells and neutrophils. Remember, neutrophils, they are among the cells that we have in the acute inflammatory response. And then you have numerous bacteria demonstrated in the alveolar fluids through gram staining. So that is it, that a picture of it. So you have polymorphonucleus and some red blood cells. So here, these ones are few, the red blood cells and the polymorphonucleus, basically the neutrophils. And then we have the widening of the septa and lot of edema. Remember, the features of acute inflammation is that we have edema, we have the reddening and all that. But realize here we have few red blood cells. Then again, you might get a mild pleurisy, and they appear, the liver, the lung appear enlarged and heavy. Red hepatization, that is an early consolidation. Usually the phase takes around 2 to 4 days. And it appears like a liver. Yeah, it has a liver-like consistency of the affected lobe on a cut section. Grossly, the affected lobe it appears red, it is firm and consolidated. The cut surface of the affected lobe, it is airless, it is red pink. Again, it is dry and granular and has a liver-like consistency. Histologically, the edema fluid of the preceding stage is usually replaced by strands of fibrin. So initially in stage 1, the stage of congestion, we had edema fluid. But again, in stage 2, we are having this edema fluid being replaced by strands of fibrin. There's a marked extracellular exudate of neutrophils. So neutrophils are really increased in number in stage 2. It is histologically. And we also have a good number of red cells, the erythrocytes. So many neutrophils show ingested bacteria. If you check histologically, yeah, that's what you're going to get. And the alveolar septa are less prominent than in the first stage due to cellular exudation. So there goes a picture of that. So you have, in the previous picture, we had some neutrophils and erythrocytes. So here we have many of them. And then we have the edema fluid being changed or rather transformed into fibrin strands. So we have stage 3, which is gray hepatization, and it is late consolidation, usually lasts about 4 to 8 days. The affected lobe is firm and quite heavy. The cut surface, it is dry, granular, and gray in appearance with a liver-like consistency. So still here, despite the change in color, the liver has, the lung has a liver-like consistency. The color is changing from red to gray, beginning at the hilum and spreads towards the periphery. So histologically, the fibrin strands are dense and more numerous. So it is just simply continuation of the previous. So we had at red hepatization, the edema fluid was being changed to fibrin strands. The fibrin strands were forming, replacing the edema fluid. So here we have the fibrin strands, they become more dense and more numerous. And the cellular exudate of neutrophil is now reduced due to disintegration of many inflammatory cells, as evidenced by cognitic nuclei. We also have reduction in the red cells. The erythrocytes, they are also reduced, and the macrophages begin to appear. The cellular exudate is often separated from the septal wall by a thin clear space, and the organisms are less numerous and appear as degenerated forms. So there goes the picture. So we are having the neutrophils, they are reducing in number as we are having the macrophages adding in number. And then you have a dense fibrin. So unlike the previous, we had fibrin, but it wasn't dense, it wasn't much. So here we're having much of fibrin. And again, the lung appears firm and gray. And again, you may get fibrinous pleuris. It is also a characteristic feature in stage 3. Then the last stage, we're having stage of resolution. Basically, it begins by the 8th or 9th day. if there's no chemotherapy. So under normal circumstances, if there's no antibiotics administered, it begins around the 8th or the 9th day. And again, it takes about 1 to 3 weeks to be completed. But however, if person has used antibiotics, then the resolution might start about day 3, about the 3rd day. Yeah. So grossly, the previous solid fibrinous constituent is being liquefied by an enzyme action. So we are having the loss of fibrinous stance. The fibrin stance here in this stage, it is being liquefied and eventually restoring the normal aeration of the affected lobe. The process of softening begins centrally and spreads to the periphery. So here, let us go to the previous stage, previous slide, sorry. So here, we are having a change of color from red to gray. It begins at the hilum and then spreads towards the periphery. Then here, we are having softening that begins centrally and spreads to the periphery. So cut surface is gray-red or dirty brown, and it appears frothy. It has some form. Yellow creamy fluid can be expressed on pressing. So there goes the picture. So you're having, as in the resolution stage, we are having the affected lobe returning to normalcy, back to its normal previous texture here. And predominant cells, we have the macrophages being a lot of them, and we also have some bits of lymphocytes. Histologically, the macrophages are predominant. We've said about that. And the fibrin strands, they'll be fragmented. Histologically, they'll be fragmented. There's fragmentation of the strands of fibrin, and this is because of the progressive enzymatic digestion. So remember, we say that the fibrin here, it's being liquefied. So that is why we are having, histologically, we are having fragmented strands of fibrin. So alveolar capillaries are engorged, and yes. Clinical presentation, we basically have, you may have shaking chills, you may have hotness of body, you may have malaise and pruritic chest pain, especially when there is pleurisy. If there is involvement of the pleura, the visceral and the parietal, you'll get pleuritic chest pain. Then at times you may get predominate and delirium may also be present. You may have appetite, loss of appetite may also be present. You may have headache. You may have dyspnea and cough that has sputum. That is, the sputum is either mucoid, it can be purulent, or some other time it can even be bloody. So the patient might be tachycardic, may have a raised heart rate, might have a fast breathing, and sometimes you might get cyanosis, if the patient is severely hypoxemic. The lung tissue, the lung is typically dull to percussion. Auscultation reveals bronchial breathing, and you might well get crackles throughout the affected lobes. There's generally marked neutrophilic leukocytosis. When you do blood cultures, about 30% they're going to be positive. So blood culture is not a good, or rather, only 30% of the cases you might get positive blood cultures. Then you may get consolidation on the chest X-ray, And sometimes you may get upper abdominal tenderness. It's sometimes apparent in patients with lower lobe pneumonia. So depending on the lobe affected, you might get upper abdominal tenderness, especially the lower lobes if they're involved. When pleuritis is present, it is accompanied by pleuritic pain and pleural friction rub. So we have talked about that. Investigation that you're going to do, you may do culture of the sputum, you may do full blood count. So culture of the sputum will reveal the organism that is affecting. Again, full blood count, you may as well do it. You might get elevated neutrophils. Then depending on the stage, you might as well get elevated lymphocytes. You can do blood culture, and this is an indication of bacteremia. It actually marks, it is a marker of severity. But remember, we said it's only about 30% of the patients will, when you do blood culture, you're going to get positive. It will be positive test for blood culture. You can do oropharynx swab, and the swab you're going to do polymerase chain reaction, the PCR, and check the DNA for mycoplasma, or rather the RNA for mycoplasma, pneumonia, and other atypical agents. Remember, it is very hard to culture mycoplasma. Chest X-ray, you can do it, and global pneumonia may reveal patchy ossification, evolves into homogeneous consolidation of the affected lobe, and then you may get patchy segmental shadowing. This basically happens in bronchopneumonia. Bronchopneumonia, you're going to get typically patchy and segmental shadowing, but in lobar pneumonia, you're going to get patchy opacification. Management, the management, you're supposed to target on oxygenation, the fluid balance, and antibiotic therapy. In severe and prolonged illness, the patient may as well require nutritional support. So under oxygen, whom should you give the oxygen? A patient who has tachypnea, has fast breathing, has low oxygen levels in blood, who has hypotension or acidosis, with the aim of maintaining partial pressures of oxygen to around greater than 92%. So under fluid balance, whom are we supposed to give fluids? But if the patient can take orally, the better. But very severe illness, very severe pneumonia, in older patients and those with vomiting, you may as well consider giving intravenous fluids. But if the patient can take oral fluids, then the better it should be encouraged. Antibiotic therapy, this is prompt administration of antibiotic improves the outcome, and the choice of antibiotic is basically guided by the clinical context, the way the patient is. You might choose to give an intravenous antibiotic, or you give an oral antibiotic. Then severity assessment, depending on how severe the patient appears to be, then it will guide you on the choice of antibiotic. Local knowledge of antibiotic resistance patterns, and at times epidemiological information. So there are some antibiotics, they do not work in the West, but here in Africa it works. So with the epidemiological information and the local antibiotic resistance patterns, it may really help on which antibiotic therapy you're going to give. But the bottom line is prompt administration of antibiotics basically improves the outcome. Remember, we say that the patient, the morphology you are having, if the patient is given antibiotics, by day 3, the resolution stage might start. But again, if under normal circumstances the patient has not been given antibiotics, it may start around from day 8, around day 9, and may last for around 1 to 3 weeks. So again, this patient might present with pleural pain, so you might decide to give analgesia. Just give paracetamol, or you can give non-steroidal anti-inflammatory drugs, such as you can decide to give diclofenac, you can give brufen, and the likes. And in some patients, opioids may be required, but again, they're supposed to be used with caution, especially with those patients who have poor respiratory function, because the opioids, they normally depress the respiration, respiratory function, they depress it. So if the patient has poor respiratory function, then you might kill the patient even faster if you give strong opioids, because it will depress even further, hence you lose the patient. Physiotherapy is not usually indicated for patients with a community-acquired pneumonia, although it may be helpful to assist expectoration in patients who suppress cough because of diuretic pain, especially the elderly. Physiotherapy can be done to help them expectorate the sputum, to remove the sputum. Physiotherapy might be important. Possible complications, we are having organization as a complication, or rather you can call it canification as a complication. About 3% of cases. We are having the exudate. So instead of the exudate clearing, you might have ingrowth of fibroblast from the alveolar septum, resulting in a fibrosed, tough, airless, leathery lung tissue. And this we call it canification. It is a type of post-pneumonic fibrosis. So we're having the exudate getting fibrosed, leading to a fibrosed, tough, airless, leathery lung tissue. So you can have this as a complication, canification. Another one is pleural effusion. So that this occurs in about 5% of the treated cases of global pneumonia. They develop inflammation of the pleura with the fluid accumulation. Then about 1%, another complication is emphysema. About 1%, you may have encysted pus in the pleural cavity. So when you have, that is in cases of global pneumonia, when you have encysted pus in the pleural cavity, then we term that as emphysema. We can as well have lung abscess. It is a rare complication of pneumonia, and usually there is a secondary infection by other organisms. We can have metastatic infection, so you start with pneumonia, and then with time the infection spreads to the pleural cavity, and then it extends to the pericardium. Remember the organs that we have in the mediastinum. So the infection may extend to the pericardium and the heart, causing pleuritic pericarditis, bacterial endocarditis. We are having myocarditis and other forms of infection encountered rarely in lobar pneumonias. You may have extension of the infection to the ear, getting otitis media. You can get mastoiditis. It may extend to the meninges, getting meningitis. It may extend to the brain, forming a brain abscess and pleuritic arthritis in the joints. The prognosis, fever may persist for several days. However, the chest X-ray often takes several weeks or even months to resolve, especially with the elderly. Delayed recovery, it usually suggests a complication that has occurred, or it will tell you that the diagnosis might not be right. The mortality rate in adults with non-severe pneumonia is good. Sorry, is very low. Sorry, very low. Actually, less than 1%. But the hospital deaths are typically between 5 to 10%, but maybe as high as 50% of the illness, of the severe illness. Prevention, we are supposed to encourage the smokers, they should stop. They should stop taking smoking, sorry, they should stop smoking. Then you can as well give vaccination of influenza and pneumococcal, especially in patients who are at high risk of pneumonia, and this includes the elderly above 65 years of age with chronic lung, chronic heart, chronic liver disease, chronic kidney disease, diabetic, and immunosuppression. And again, because of the mode of spread, Legionella pneumophila, it has an important of public health implication. So when you get a pneumonia case and you isolate this organism, then you're supposed to notify, to give a notification to the appropriate health authorities to find the potential source of the organism. Again, in resource poor settings, tackling malnourishment. Remember, malnourishment and immunity, they go hand in hand. When you are well malnourished, then your immunity is good. When you are malnourished, then your immunity is not very well. In case of indoor air pollution, you're supposed to handle that and encourage immunization, especially against measles, pertussis, and Haemophilus influenza type B. They are very important in children. Continuation of the prevention for the hospital-acquired pneumonia, good hygiene is paramount at facility level, particularly with regard to hand washing and any equipment used. Like you might do a procedure to a patient. Maybe the patient is comatose, and then you give or rather you insert an endotracheal tube. If the equipment is not sterile, then you're going to introduce infection in the lungs. Then you're supposed to take steps to minimize the chances of aspiration and to limit the use of stress as a prophylaxis with proton pump inhibitors. Thank you very much. If there are any questions, you can comment. You can like the videos. You can share the videos. Subscribe to our channel, Meshack Kitaka. Medical conditions will be uploaded at least twice every week. Thank you very much.